Hello, my name is Jacob Lever and I'm presenting on behalf of my collaborators and my supervisor, Dr. Andrew Hill. I'd firstly like to sincerely thank the International AIDS Society for providing me with a scholarship to attend this event and present our findings. So as we all know, in 2014, UNAIDS set 3 ambitious targets to increase global coverage of HIV care by the year 2020. And these are Target 1, 90% of all HIV-positive people living with all HIV-positive people to be diagnosed. Target 2, 90% of those diagnosed to receive antiretroviral treatment. And Target 3, 90% of those on treatment to achieve viral suppression. This means that in the final category, 73% of all HIV-positive people should be achieving viral suppression by the year 2020. The numbers here in white show how many people should be in each category, given that nearly 37 million people are estimated to be living with HIV globally. Using the most recent data from UNAIDS and a systematic review on viral suppression rates by McMahon et al., this global cascade estimates where we are currently compared to those targets. Just over half of all HIV-positive people know their status, and 41%, about 15 million, are on treatment as of March 2015. The numbers in white show the most current estimates for the number of people in each category worldwide, and where the targets are not yet reached, red arrows illustrate the gaps in the cascade. And this is where we're missing the targets, and we will define these as breakpoints. Can these UNAIDS 1990 targets be reached? This is an extremely important question, and we aim to analyze published national HIV treatment cascades to see how close countries are to reaching these targets. 11 full cascades were analyzed, the list on the left, and 9 partial cascades were analyzed, the list on the right. The cascade, which shows the average results for the region of Sub-Saharan Africa, was constructed by combining UNAIDS estimates and an average of data from 30 countries. And it's important, obviously, due to the significant size of the epidemic in this region. However, of course, it's a huge range of results from countries within this region. And the partial cascades were deemed incomplete because they either did not report numbers of people at each stage of the cascade, or they did not include estimates for all 3 of the UNAIDS targets, or because the viral load thresholds were not reported. So we extracted data for these 6 stages, and however, definitions and estimation methods varied between cascades slightly. Linkage and retention, here in italics, were defined quite differently between countries. This ranged from attendance at clinics or HIV healthcare appointments to blood tests within a given time frame or certain frequency following the diagnosis. And if there was a drop greater than 10% between any of the 3 UNAIDS targets, then we defined this as a breakpoint in the cascade. Identifying breakpoints is important because it allows us to analyze the gaps and to focus the prioritization of resources to fixing them. This cascade for Switzerland was constructed using data from 2012 from the Swiss HIV cohort by Koller et al., and it shows the closest published national data to reaching the 73% viral suppression target. But 2 breakpoints are indicated here with red arrows. The largest breakpoint in this cascade is at diagnosis, and the second breakpoint is where 87% of those diagnosed receive treatment. 68% of all HIV-positive people in Switzerland are now achieving viral suppression. And while Switzerland is the closest to the final UNAIDS target, this cross-sectional cascade, using data from 2013 from Russia by Pokrovskaya et al., shows the lowest rate of viral suppression of available published cascades. Of the 1.36 million people living with HIV in Russia, less than half are diagnosed, and this is breakpoint 1. However, Russia's greatest breakpoint is between diagnosis and the provision of antiretroviral therapy, and this is breakpoint 2. Overall, 9% of all HIV-positive people in Russia achieved viral suppression. So UNAIDS Target 1 is calculated by dividing the number of people diagnosed with HIV by the estimated number of people living with HIV in that country. Both of these numbers are estimated in different ways with different testing procedures in each country. The total HIV epidemic size is estimated by back calculating using epidemiological models based on data from anonymous, unlinked seroprevalence surveys, and these are done in small cohorts, either from the emergency department or sexual health clinics, or small cross-sectional studies of high-risk groups. Cross-sectional cascades may mean that there's greater loss to follow-up, or even double counting of patients, and these may be less reliable. However, longitudinal cascades are more expensive and are difficult with large epidemics. So this graph shows how each of the countries analyzed in this analysis are doing relative to target 1 of 90% of all HIV-positive people to be diagnosed. Of course, these figures are point estimates, and we've taken the average figure reported, while sources give varying ranges with confidence intervals. Diagnosis was the largest breakpoint globally, and was individually the greatest point of attrition for Switzerland, the United Kingdom, Netherlands, the region of Sub-Saharan Africa, Colombia, and Ukraine. The percentage of all HIV-positive people receiving antiretroviral therapy is calculated from a combination of records from healthcare facilities, governmental drug purchases, or pharmacy record data. Varying drug regimens were not differentiated between them. There was a large difference between definitions of linkage and retention in care, as I've said, between the cascades. Although these categories are very important for evaluating national and local healthcare targets, there are no direct UNAIDS 1990 targets for these stages. Therefore, linkage and retention were not analysed for breakpoints in the comparison between countries. Linkage and retention may need more specific guidelines and attention in the future, as they are very important steps to provide treatment for those diagnosed. Data comes from a range of years from 2010 to 2014, and over this time, each country has different treatment initiation guidelines. Following the START trial and the new WHO guidelines for test and treat, national treatment initiation guidelines will shift again, and we're not sure exactly how long those will take to come into place in each country. But countries adopting test and treat should theoretically approach the 100% between diagnosis and those receiving therapy. Other categories have been reported, such as eligibility for treatment or adherence, and although these provide important local data, they're not necessary for the UNAIDS 1990 goals and are not easily comparable between countries. This graph shows the percentage of all HIV-positive people receiving therapy for all of the countries in the one region included in this analysis. The highest is Switzerland at 71%, and the lowest is Russia at 11%. Providing therapy to those diagnosed was the largest breakpoint for Australia, Rwanda, Denmark, Brazil, Cuba, the United States of America, Estonia, Vietnam, Georgia, Kyrgyzstan, and Russia. The number of people successfully treated, measured as viral suppression, is defined by UNAIDS as maintaining a viral load of under 1,000 RNA copies per milliliter. However, many cascades report undetectable HIV RNA, and these definitions range from under 40 to under 500 copies per milliliter. This was sometimes reported as an average over multiple tests throughout a year or more, or as a single test from single result from the most recent test. And this obviously impacts the final percentage in the cascade significantly, and again it reduces the comparability between countries. An example here is from Brazil, and currently the stringent definition of 50 copies per milliliter is used for calculating the percentage virally suppressed, resulting in 35% of all HIV-positive people being undetectable. However, in other countries under 1,000 is used, and if this was used in Brazil, then 40% would be categorized as virally suppressed. So this graph was actually already presented in the plenary this morning, and it shows the viral suppression thresholds that are used for each country are underneath the country names, by the way. It shows all the countries included in this analysis in order of percentage achieving viral suppression. And great disparities exist, especially between Western Europe, and Australia, the countries on the left, and the Eastern European countries on the right-hand side of the graph. And this was marginally the greatest breakpoint for British Columbia, which is where we are now. This graph shows how each of the countries analysed in this paper are doing relative to the UNAIDS targets 1 and 2. So the flags for each country mark where they are on the graph. The region of Sub-Saharan Africa is represented here as an average of 30 countries, which are listed below. 90% of all HIV-positive people should be achieving diagnosis, and the dotted line coming up from the x-axis marks UNAIDS target 1 and 2. The dotted line coming across from the y-axis marks UNAIDS target 2. Sorry, I said the other, target 1. So Ukraine has the lowest percentage diagnosed at 44%, while Russia has the lowest percentage of those diagnosed receiving treatment at 23%. And this may be related to national treatment eligibility guidelines. Now, if we compare target 2 and 3, 90% of those diagnosed should receive antiretroviral therapy, and the dotted line coming up from the x-axis shows UNAIDS target 2. In this graph, the dotted line coming across from the y-axis shows target 3, and there's wide variability between countries for the percentage of those diagnosed receiving treatment. As you can see, Denmark, Belgium, Australia, and Switzerland, above the dotted line, are achieving greater than 90% viral suppression for those on treatment. So in conclusion, no country yet meets the UNAIDS final target of 73% achieving viral suppression. This is the most important category for achieving individual good health, but also for reducing transmission and ending the epidemic. Large disparities exist, especially between Western and Eastern Europe. Although all cascades are constructed from the most reliable and the largest available national data sources, comparison between countries is difficult because of high heterogeneity in reporting methods and definitions of stages between countries. In 2020, the UNAIDS targets will increase from 90% to 95% for each of the 3 categories as a fast track to the end of the epidemic by 2030. Currently, diagnosis remains the largest breakpoint globally, and therefore we need to focus on testing. Identifying breakpoints allows us to prioritize the resources to fix them. And we conclude that to measure progress annually and to facilitate better comparison between countries, which is extremely important to ending the epidemic, a standardized reporting methodology should be implemented. Thank you all for listening, and thanks to my colleagues for providing data and assisting in this research project. I'd especially like to thank the International AIDS Society for awarding me with a scholarship to present this again. And the references are all here for all 20 cascades, and all of the individual cascades will be available online. I'd also like to warmly welcome any updated data from countries already presented here, or any countries that we've not yet found data for. Thanks again.